So what we were talking about last time was the somatosensory system, and we started out in the periphery, talking about how mechanical deformation or painful inputs are transduced into an action potential. How that action potential travels back toward the CNS via the peripheral process of a dorsal root ganglion neuron. So today, we're going to complete our discussion on the somatosensory processing, and we're going to talk now about what happens after it gets into the spinal cord. Okay? So, first couple of slides are going to be a review of material that we've covered either last time or in the previous block. So, again, remember we're talking about sensory processing. So the first order neuron is going to be our DRG cell, and we've been focusing primarily on receptors that are out in the skin. For touch, that information is carried by those A-beta fibers. They're large diameter, heavily myelinated, shown here in green. When you come back from break, we'll talk about this other group, which are called proprioceptors, and carrying information back from muscles, where we are in space. So that information, remember, kind of an antidromic propagation of the action potential. The terminal for at least 3 out of 4 of the receptors, 3 out of 4 of the D-type endings, have mechanosensitive receptors that are part of the peripheral process itself. So when there's deformation, then the mechanical force causes those channels to open, allowing influx of sodium, called a receptor or generator potential. And if that receptor or generator potential reaches threshold, the action potential is sent back toward the cell body. And that's kind of where we left it, but now we're going to see that it's going to bypass that, and we're going to follow it into the CNS and ultimately up to the cerebral cortex. Okay, you've seen this image before. Just to remind you of the pathway. Again, I will not ask you to find the pathway on the cross-section or on a sketch or ask you where the cells of origin are anymore. But just so you know, right now you do have to kind of remember how things are getting where they're getting and still where things cross. That's still kind of important. But remember, for touch, we have the first order neuron again here in the dorsal root ganglia. That information now is going to come into the CNS. The central process of the DRG cell enters that dorsal column, travels up to the caudal brainstem. We have a synapse in the nucleus gracilis or cuneatus, depending on whether it's upper or lower limb information. The cuneatus and gracilis neurons send axons out that cross the midline and form that medial lemniscus. Medial lemniscus then continues up to the thalamus, and from the thalamus we go to our postcentral gyrus. And what we're going to focus on today is primarily this area, the postcentral gyrus and the projections from the thalamus. Just to remind you, pathway I just showed you was for touch sensation from the body. For the face, this might be the last time you have to deal with trigeminal nerve. But this block, we still have to think about it. Trigeminal nerve is carrying that same information from the face. It enters. So the first order neuron is in the trigeminal ganglion. Central process enters. There's a synapse in the main sensory nucleus. Main main sensory nucleus sends its projections across the midline, and essentially they join the medial lemniscus to go up to the thalamus again. Let's get this out of the way so we get into the new information. Just a reminder, your spinothalamic tract is going to carry pain information. So touch and pain have very unique pathways for getting their information up to the cortex. But again, they kind of start out the same. The cell bodies that are detecting pain are going to be in a DRG neuron, or DRG in a dorsal root ganglion. Here's the central process bringing that information into the dorsal horn of the spinal cord. So here's the first difference between touch and pain. These afferent synapse within the spinal cord itself. They synapse on a neuron in the dorsal horn. And it is that neuron that crosses the midline right at that level, forming the spinothalamic tract. And then it just goes on up to the thalamus, and from the thalamus on up to, again, our postcentral gyrus. Hopefully that still sounds vaguely familiar to you. Okay? And remember, pain from the face. Again, first order neuron is going to be in the trigenital ganglion. The axon enters, or central process enters, descends to the spinal nucleus of 5. And just as we saw before, there's a synapse. And then that second order neuron joins the spinothalamic tract to carry pain from the face up to the thalamus. Okay, so again, just there as a review. So now, let's go a little further. We pretty much stopped at the level of the thalamus in our previous 2 blocks. So now I want to take it on up to the cortex, talk a little bit about how that's processed. We're going to start out again primarily, well, the first part is really for both touch and pain. We focus a little bit more on the touch. Second half, I'll focus more on pain. So, again, let's get reoriented. Here's a lateral view of the cerebral cortex, the central sulcus, and the post-central sulcus, and the gyrus, or the area of brain tissue that's in between those 2 slits, is called, all of these are equivalent. Post-central gyrus, you can call it the primary sensory cortex. Call it S1 for sensory 1, primary sensory. It's another way you'll see it. And this is something we alluded to once, but it is going to be important today. We're going to also call it areas 1, 2, and 3, according to Brodmann. I told you wouldn't have to know all of the Brodmann areas, but there are a couple numbers that we do have to bring in. You'll see why in a minute. But all of those are basically synonymous. And in the first lecture of this block, we talked about this area that's posterior to the postcentral sulcus, and that was that association areas that had much higher order processing of information, and damage to these areas, depending on the side, could produce neglect syndrome or apraxia or aphasia. So we're going to focus today on just this little strip right here. So the first thing we know from lots of studies, different parts of the body have very specific representations in the primary sensory cortex. And when we look here, so here's medial, here's the midline, here's lateral. We can see that our body representation, the lower the foot, kind of centrally, and the leg, kind of hang over that gyrus and are represented more on the medial side of the postcentral gyrus. And then we kind of follow up on the body. We get the hip, the thigh, the trunk, neck and shoulders, pretty much here on the upper surface. As we start swinging out a little bit more laterally, we see the hand and the digits coming down, a little bit more ventral. We get the face, and down here are things like pharynx, the pharyngeal muscles, and areas like the tongue. So that's a really precise, we know that different areas of the body can be localized to very specific regions of that gyrus. The other thing you should notice on here is that not all regions of the body have the same area of representation. We see shoulder, arm, elbow, trunk have essentially very little representation, and then we get out here to the hand. And we see very large areas dedicated to the hand, and in particular, to each of our fingers. Little finger, ring finger, middle finger, index, thumb. And then another area that has very large representation is the face. Is there anything you could correlate that with from the last lecture? What was also unique about, say, fingers and hand and face? How about receptive field?
Really small.
They have very small receptive fields, right? So remember what I said, if they have a small receptive field, that means there's going to be a whole lot more neurons that are covering that area. So there's a whole lot more axons coming up into the thalamus, and then from the thalamus up into the face. So there's a nice correlation between small receptive fields and large representation in the cortex. Now, if we actually looked like this map, this somatotopic map, that's kind of what we'd all look like. And that's usually referred to as a homunculus. Fortunately, our body doesn't have to follow our cortical representation. But I guess if we all look that way, it wouldn't matter. How we look now would be weird. We're like, look, everything is equal. What's the deal there? Okay? Now, are we the only species that has this kind of specific representation? You might think so, because, you know, we've evolved and we're very specialized. The answer is no. This creature is called a star-nosed mole, for obvious reasons. Here's his little, he lives basically underground, and he tunnels. Look at the size of his forelimbs. Huge paws for digging. But he also has this very unique appendage kind of around the area of his nose and his mouth. And this was kind of the animal that a lot of the somatosensory studies were first done, looking because this was accessible. And if you kind of do a time lapse, here's a little particle, so he's in the dark, he can't see. Here's a little particle, it touches those appendages, and he can basically use that to feel what's going on in his environment. And you can see that happening in multiple, this was one set, and then this was another set going by. And what they did was, again, they mapped out where each of those appendages terminated, or where the sensory information from those appendages terminated in his sensory cortex. So here's all the little digits. And there are techniques you can use to actually show where they are. And where you see this coloration, you can actually see almost an exact representation of that appendage in very specific areas of this creature's cortex. So there's also a molunculus that can be used. Okay, let's do one more example of this. Creatures with whiskers. This one, we're going to use this little rat as a representative of those animals. And again, you can map the position of each one of these whiskers. Notice there's a specific row, A, B, C, D, E. And again, when you map these into the rat's sensory cortex, here's the rows, and each whisker has its own specific area that's going to be activated. And that's why you should, and they use those, rats move around and they're nocturnal. Rodents in general are nocturnal. They don't have a lot of light. So they use those whiskers to really feel where they are in space. Same thing for cats. So you never should cut whiskers on any of these animals, because you would seriously impair their ability to navigate and to get around. Okay? So we are not unique in having a representation. I guess that would be a rodunculus. That sounds like a good word, rodunculus for the little rodents. Okay? So the sensory cortex, especially in mammals, is very precisely organized where this information ends. Now I have to come back to our friend Brodmann. And remember, he was the neurologist, and he took little bits of the cortex from all over, and he measured the thickness of those 6 layers. And based on that thickness, he defined something like, 52 different cytologically distinct areas. We're going to focus, here's the postcentral gyrus between these dashed lines, and within that area, he defined 3 distinct regions. And I think these were the first 3 he did because they're sitting right there on the top. Probably were the easiest ones for him to get into. And he defined what's called Area 1, which is a strip that goes right down the center of the postcentral gyrus. And then just caudal to that is another strip called Area 2. You just think of that as being adjacent to the postcentral gyrus. And then Area 3, which is next to the central sulcus. You can see these continue around onto the medial side as well. And now we're going to see why it's significant that we have this division. So that was an anatomical division. But now we know that there's functional significance to those 3 strips as well. So those are three of Brodmann's areas that you do have to know for now. Further studies actually subdivided Area 3, and these were functional studies. So here, where's Area 3? There it is. This area. So he took this, in this image, we take the postcentral gyrus out and just lay it out here. So this would be the area where the central sulcus was located. And there's an Area 3A and an Area 3B. And then here's 1 and here's 2. So we're not talking about a huge bit of tissue, but we can separate it into these divisions. Okay, so why is this significant? So let's just look at this little piece and blow it up. And here we have the post-central gyrus. Everybody oriented to that, okay? So central sulcus over here, post-central sulcus. Here's area 3, area 1, area 2. Here's the thalamus. And we know here's our friend VPL and VPM. And when they project to the cortex, it turns out that if information is coming from our muscles, it is going to terminate in area 3A. If it's coming from the skin, from our cutaneous receptors, it terminates in 3B. So now, before we said proprioception and touch, they run together pretty much all the way up from the dorsal column, cuneatus gracilis, up to the thalamus. But when we get now to the somatosensory cortex, they each have their own area of termination. We're not going to talk about 3A anymore today, mostly because we haven't talked about proprioceptors yet. The other thing to notice, let's look at this output from the thalamus. This is a very strong input to area 3. There are very few direct thalamic projections to area 1 or area 2. Okay, so the bulk of the thalamic input is going to that area of the somatosensory cortex that sits right adjacent to the central sulcus. But notice axons arising from area 3, A and B, they send projections to area 1. Those neurons send projections to area 2, and then we're going to talk a little bit about this secondary sensory cortex in a few minutes. And kind of what we're going to see is that as we flow from 3A and 3B, let's just say with 3B. 3B is receiving the important information as to location of an input and intensity. Without 3A, you cannot localize an input. But then, as we begin to move into these other areas, we're going to see that we're going to begin to add nuance to that input. There's going to be convergence of information. So let's see how that works. And again, here's just our cortex showing these various bands. So let's start with area 3. This is the obligatory first step in cortical processing. If we don't get information into area 3, we don't feel it. We don't know where something is touching us or how intense the touch is. This is the same for pain. Pain is going to be following the same distribution pattern. So area 3 is, again, buried pretty much in the central sulcus. Receives the majority of the thalamocortical input and is essential for localizing the localization and intensity. If you could, probably would be challenging, but if you could just lesion area 3, that's when you would have these deficits in any kind of tactile or pain sensation. Okay? So let's Again, here's our little bit of the post-central gyrus. And now I'm going to cut out just a little chunk of it here. This area here in 3B. And if we look at it, what we can see again is kind of the precision. Here's an area that responds to input from your second digit, D2, third digit, fourth digit, fifth. So we have very precise input to this area. Not only that, remember one of the other things we talked about on Tuesday was that these different receptors had the physiological property of adaptation. Some were slowly adapting, some were rapidly adapting, and that had a lot to do with, am I going to be able to feel something and detect its shape versus feeling something that's maybe moving across the skin or texture. And each of those receptors have their own little column within the space dedicated to each of the digits. So we have these rapidly adapting, let's look here at digit 3. We have these rapidly adapting information is coming up into this little area and slowly adapting coming there, coming just a little bit behind it. So very precise information coming in. Am I feeling something moving, changing position, frequency, or is it a kind of a static where I want to be able to interpret a shape? And again, just to review, that input is going primarily into layer 4. Okay, so now I can feel something. I know that something is touching the tip of my finger. So why do I need area 1 and area 2? Well, it turns out they do get a little bit of input from the thalamus, not respecting, you know, and the further back you go, the weaker the input. But what we're going to see is now, it's fine if I know something is just touching the tip of my finger. But if I'm touching something, is it only the tip of my finger that I want to know about? You know, I want to know something about the next joint. I might want to know something about where my thumb is. So now, how do I get information from more than one area to converge on populations of cells? Okay, so we're going to see in the next slide, these areas have much more complex representations of the receptive fields. We get convergence from multiple areas and from different types of receptors. We're not going to have this specificity. We're adding a lot more information. Turns out if you have lesions in these areas, again, probably pretty hard to keep isolated, but experimentally you can do that. You get deficits in using the tactile information, as it says here, to discriminate texture, which is primarily area 1, or the shape of an object, area 2. So how does that work? Let's look at this diagram. So here's input to area 3B. And the area would maybe respond to receptors that are at the tip of that middle finger. Okay? Okay, that's all well and good, like I said, but how important is it to know exactly, unless I'm really just kind of capping that one finger and I want to know where it is, but remember I keep saying, we got to remember this is lots of things happening at the same time. So area 3, we can localize it, but now when area 3 projects to area 1 or area 2, notice that those neurons, the representation, the receptive fields, expand. So a neuron here in area 1 may respond to input from the tips of all of the digits. When we get to area 2, It's not only responding to the tips, but maybe the whole finger and even part of the palm. And then area 5, and it's area 5, that's that association area. It gets even more complex. You can have bilateral representation, crossing over from the corpus callosum from the other side, and that's where you get into some of the other effects that we talked about a week ago. So does everybody get the idea of what I'm saying here? Any confusion about? So we're basically taking points, and now we're saying, okay, let's see if we can get better representation. So how does that work? What does it mean? So here's a primate, and they put a little grape in this funnel, and the primate's job is to take the grape out, and if he does it, he can eat it. Okay? These primates are very driven by food rewards. So we can see here, he's moving his hand, and he needs to have some information from all of his digits. Think about if you were to pick something up. I don't have anything small here, I got a battery. I need to be able to come down and close my hand and get information from everything that's touching it if I want to hold on to it. And then he's got to kind of draw it back up along the side of that funnel. Now what if they lesion area 2? He can move, his motor cortex is fine, so we're not messing that up. But now when he goes in, he doesn't have the information anymore from all of his fingers. So it'd be like me trying to pick up this battery with one finger. It's not going to work. I need to know, especially us, we have opposable thumbs, I need to know where my thumb is also, so I can bring it over. So this poor little monkey in this case kind of tries to feel it, and he may be able to touch it, but he can't get all of his digits to work together to bring that grape out. Okay? Make sense? Questions?
If this happened to a person, would they still be able to do this task? Like, they're going to have to feel, or is it just by looking at it, could they still,
Well, you could, after, not initially, but initially we do learn, we do wind up having ways of compensating. And yeah, you could use your vision, and you might be able, because again, you have your motor cortex intact, and you might be able to probably take practice to figure out how to get that to happen. And that's with a lot of brain injuries, we begin to compensate with other parts of our brain. Okay? So again, this gets to this idea, we talk about everything in little minutiae. Now we have to bring it all together to say, how does that really function? Okay, let's move on to that secondary, what I said was a secondary somatosensory cortex. And it's located, this pink area, so it's kind of at the base of the somatosensory, primary sensory cortex. And it basically, so let's take a section through here. Again, here's 3A, 3B, 1 and no, they don't have 2 on there, but 2 would be in here. And S2 basically sits right next to that insular cortex. Remember, that's that cortex that's buried under the parietal and the temporal lobes. And again, things get even more complex here. These cells can get input bilaterally, again, for more complex behavior. There's some really interesting pain-sensitive neurons in this area also, which aren't important for localizing pain, but for adding a little bit of an emotional context to a painful input. And this area has a lot of connections with the hippocampus and may play a role in that tactile learning and tactile memory. Again, I don't have to look at this device anymore. I know this is a mouse. I've learned that from many years of using this mouse, what it feels like. So again, each of these areas add another level of integration, another level of complexity to how we're using that sensory information. So here's an interesting patient. This is a patient who had some autoimmune disease, and she lost her myelinated A beta fibers. Interestingly, only in the periphery. Let's just say trigeminal nerve was not affected. So she said, this is patient GL. Patient GL lost her sense of touch, but she still could detect pain and temperature. Does that make sense? Yeah, because they're coming up through different pathways, right? Pain fibers are A deltas and Cs. Again, why they're not affected? Autoimmune diseases are a little strange. So they did some studies. So GL is in blue, control patient is in gray. And they did some vibration on her palm. They did some vibration on her arm. And, you know, she's below 50% saying something, I'm feeling something touching me. Chance maybe. Whereas the control patient, you know, 100%, I know where you're touching me. And then they did stroking. Vibration is kind of fast by implication, very rapidly changing. But then they just stroked the area. They stroked her palm, improved a little bit, but still pretty much a chance. But when they stroked her arm, she could detect that stroking. What's different between the palm and your arm? I think I heard somebody say hairs. Yeah. So the hairy skin seemed to have some ability to detect it. However, she couldn't localize it. The next experiment they did, so she couldn't tell you anything about intensity. Oops, they changed GL to green here, and you know, went to control purple. But so she couldn't tell you anything about the intensity, but she could tell you something. If it was on the arm, she could tell you something about it had a nice feeling. I mean, you know, somebody stroking your arm, patting, you know, a little rub. It has a nice feeling. Forehead, no difference. Does that make sense? Yeah, because cranial nerve 5 is intact. No issues there. Controls, of course, could feel everything. So she did not have discrimination. She couldn't tell you where it really was, but there was an emotional impact with the stroking. So then the question is, if you don't have A betas, where is that information coming from? Well, it turns out, you know, we always tell you things as though they're black and white. There are a subpopulation of C fibers, which normally carry pain, and they seem to be primarily in the hairy skin that can activate those axons. But they don't project. Their pathway does not get them up to primary sensory cortex. I'll show you where it goes on the next slide. So here's a cell, and if you're doing it pretty fast, these, let me look, no, here's, if you're doing it, let me get, okay. Yeah, so if you're slowly stroking 2 millimeters per second, these cells fire during that stroking. If you increase the speed, again, suggesting more vibration, we don't see them responding quite as well, although they'll have some response. That's still pretty slow. So slow stroking is most effective, and that would probably be the most pleasant. And then when they did the functional MRI, okay, remember these T fibers are not detecting pain. And let's look at the normal subject first. Here's primary sensory cortex, and it's lit up. Somebody is touching the forearm. But notice that area is not lit up here in patient GL. Let's look down here. This is the area of the secondary sensory cortex. Here's the insula, and that area does show some activation. And even in the control subjects, here's S2, here's the area closer to the insula, and what we see is that these C fibers tend to terminate in the secondary sensory cortex, and maybe a few of them in the insula. So again, that area is not for localization, but it adds an emotional tone onto the tactile stimulation. Now it turns out that these C fibers do get associated with the bases of our hair follicles, and that's why you don't see it in the glabrous skin. You only see it in the hairy skin. Okay, one more thing for touch. Is there plasticity? Okay, so again, here's area 3B. And here's, if you were to map it out, you would find individual digits. So these numbers, here's digit 1, 2, 3, 4, 5. And as you might expect, our index finger, our middle finger, and ring fingers have kind of a large representation. Little finger, not quite so much, but it's there. And then what if you remove digit 3? And you wait 2 months in this case. Well, you can touch what's left of the stump, but you're not going to see probably any response here. But notice now when I begin to activate areas that represent the fourth and the second digit, how their area grows. Basically, they take over that area that digit 3 used to go to. And yes, they would be more sensitive. Again, that's a manner for compensating. If I lose this one, these two can take it over and become even a little bit more sensitive. One other thing you can do, what if you do a task that requires you to use digit 2 and 3 and maybe sometimes 4. And you do this over and over and over again. So you map it out again before you do the differential activation. They each have their nice little areas. And then afterwards, we see digit 2, the area, or digits, the axons from digit that would relay through the thalamus from 2 and 3, again, has greatly expanded. And a little bit for 4. So there is plasticity. Probably a lot of that plasticity has to do with spines growing on dendrites, more dendrites being produced, more synapses in response to that training. So our cortex can change, and if you never use your hand, those areas are going to stay pretty small. So before we shift gears, questions on what we just covered?
If you like play piano or something for a long extended period of time, then the whole entire, like, all 5 digits would be larger.
Yeah, all 5 areas. If you play it a lot, and I'll actually show you that when we do the cerebellum, there is data that shows like a musician will have a greater area of the cerebellum dedicated to their hand area. And the same thing would happen in this area.
When we see the same kind of plasticity, if it was like right and left hand, yeah.
Yeah. So if you remove the digit on the right hand or the left hand, you would see the same change. Now, if you own, if you're dominant right hand, maybe it wouldn't be as great on the non-dominant side, but you'd still see some changes.
What would happen if you like sewed 2 fingers together so they didn't like feel big without the other one doing something?
Well, even if you put the fingers together, you would still have individual receptors from the fingers. You might lose a little bit of the contact from right in here, but for the most part, your fingers would still be able to function, even if they're together.
Would there be like some sharing of the like space? How other than that, like the 1, 2, 4, 5?
So like in this case,
Yeah, would there be a little bit of that?
yeah, well, everybody's going to be a little bit different. And these studies were done primarily in primates I think these were mostly primate studies that they were using. But yeah, we don't all respond the exact same way. But we would see changes. Okay, let's finish up with pain. Silly question, what is pain? And there's actually a definition from the Association for the Study of Pain: an unpleasant sensory and emotional experience arising from actual or potential tissue damage or described in terms of that kind of damage. My definition of pain is pain hurts. Okay? And we want to talk a little bit about some of the properties. I'm not going to quite do the same thing with pain. I want to talk a little bit more about modulation, but we will talk about some of the properties. Pain is very complex. When we have pain, we have lots of different physiological responses. Here's the pain. Well, of course you're going to have movement, because if something hurts, you're going to pull away from the source of the pain, the heat, whatever. It can activate the sympathetic nervous system to produce sweating. That can affect kidneys. Sympathetics can affect kidneys, cardiovascular system. Your heart rate may go up. You may pass out. Blood pressure could drop. Some people don't like pain at all. You have secretion of hormones from the hypothalamus, which gives you a metabolic and an immune response. We talked a little bit about that immune response last time, with all those factors that get released in the area of the noxious input. So pain is a little more complex in terms of the response we have. So what I described to you initially was what we call the spinal thalamic tract. Goes from the spinal cord to the ventral posterior nuclei, VPM, VPL, on up to the somatosensory cortex for localization and intensity. That's called the discriminative pathway, appropriately. However, these axons that are coming out of the dorsal horn of the spinal cord, forming the spinothalamic tract, they don't only go to this primary sensory cortex. We look, there's another whole population of these axons. That's why sometimes it's called the anterolateral system. Anterolateral because it sits ventrally in the lateral funiculus. And what we see here, these other dorsal horn axons, they come up and some terminate in the reticular formation. Those are important for getting our attention. We'll be looking at, when we talk about, we have a lecture on consciousness. It's these neurons in the reticular formation that alert us and make us really initially be aware of what's going on. Some of them go up to the superior colliculus. That sends signals down to our head. I want to maybe orient my head to where am I feeling that pain? Where is it coming from? There's input that's going to come back up to the hypothalamus. And that's going to initiate those autonomic responses, cardiovascular, sweating. There are some that go up to the limbic system, which put an emotional response onto the painful input. And I kind of skipped over one, and I've got it in red here. There's also axons that terminate in that periaqueductal gray. Now we're probably going to put some function on that little structure. And this is what we're going to focus on in a few seconds. This is an area that's involved in controlling pain, modulating it. But notice, none of these reach the level of the cortex. There's a little side path that goes through a different set of thalamic nuclei, and they go again, look, S2, and insular cortex. We saw with patient GL, that was an area that kind of provided an emotional response to touch. It's also an area that provides an emotional response to pain. And this anterior, so here's kind of our insula, and there's also input to this anterior part of the cingulate lobe. And I'll talk about that more when we do the limbic system. So it does get to the cortex, just not to the primary sensory cortex. And we call this pathway the affective motivational pathway. So I do want you to know the difference between discriminative and affective motivational. When we talk about pain, there's lots of classifications. Acute versus chronic. Okay? When I feel that hot flame, when I feel that pin, that's pretty acute. Over time, maybe it still hurts a couple hours later, especially as that immune response kicks in and makes the skin feel, or the area feel much more sensitive. Get a little of that hyperalgesia. So, nociceptive pain, direct tissue trauma, all acute pain is, this is another terminology, nociceptive versus neuropathic. Acute pain is basically nociceptive. It's what's happening at the level of the tissue trauma itself. Noci refers to, again, pain, ceptive, receiving. So we're receiving painful inputs in the periphery, and you can have somatic and visceral, as we know. And then there's another type that's called neuropathic. And this is beyond just where the injury occurred. Neuropathic pain is generally caused by something going wrong either in the pathway, the signal is not being transmitted properly, or damage to the axons themselves that are carrying the signal. And there's, I've got some of it on here. And it's, you know, they talk about it as being a maladaptive somatosensory processing. So maybe when it gets to the sensory cortex, those neurons are not processing it. Maybe there's been a stroke, maybe there's a tumor that has altered the ability of those neurons to respond properly. So what are some of the ways, we've talked about some of these already. One type of neuropathic pain is called allodynia. And that is when a stimulus that was never painful now causes pain. Trigeminal neuralgia. I'm just barely touching my face. That would never have been painful, yet in trigeminal neuralgia, it sets off that intense response. Hyperalgesia, we talked about that a little bit last time. Sometimes things were painful, and they hurt a little bit, but now all of a sudden the intensity of that response gets even greater. Part of that can be peripheral, because of all those immune responses, and part of it can be occurring centrally. We're just perceiving it as being more intense than it would have ever been before. I'm not as concerned about the other three. I would like you to know the allodynia and the hyperalgesia. Dysesthesia is just kind of abnormal sensations. You know, think of like tingling in your fingers. If that gets beyond just tingling, and that gets painful, it's just an abnormal sensation. Some people have hypoalgesia, where you have decreased sensitivity, which is not a good thing, even though you think it might be. Pain is a very good warning indicator. You know, you don't want to keep doing what you're doing when you're feeling pain. And neuralgia is just, again, pain, but it usually is applied to a group of nerves. So neuropathic pain, some of the conditions. Alcoholism, alcohol kills peripheral nerves. So does diabetes. Well, obviously amputation, but it's not that the amputation itself, that'll have some nociceptive pain initially. Obviously, when you do surgery, there's trauma to the tissue. But you have patients who, you know, you've heard of phantom limb sensation, where people who have had amputations, they still feel the limb. And sometimes it's mostly the pain that they feel. It's more painful. Same thing with spinal cord injury. They don't have sensation, but if they do, it can be a pain input. Multiple sclerosis, obviously that's changing the ability of axons to transmit signals properly, disrupts action potential propagation. Thyroid problems, just again because of change in the metabolic properties, release of the hormones in that. Chemotherapy, again, that can really kill your peripheral nerves. I have a friend who just went through chemotherapy, and I have no feeling in my feet right now, she said. Okay? So, here's pain termination. So here's again S1. We see it terminating pretty heavily where we'd expect it to. And then here's that other region where we see it in the anterior, ACC stands for anterior cingulate cortex. See it better on this one. They overlap those a little weird. But this area of the anterior cingulate lobe, and as again we'll see, this is an area very much integrated with our amygdala. And our amygdala, as we know, well, may not know, but you will know eventually, is very much involved in controlling emotions and emotional responses. Okay, so in the last couple of minutes, I'm going to tell you 2 ways we can modulate pain. two intrinsic mechanisms. One is called the gate theory of pain. So here's our C fiber. C fiber comes in, synapses on the dorsal horn neuron. The dorsal horn neuron goes, form the spinal thalamic tract, or to that anterolateral system. Okay? It also, again, they're only showing one interneuron, but ultimately it will inhibit an interneuron that inhibits this dorsal horn neuron. So it disinhibits it, which means it can have an even stronger response. Now, here's our A beta fiber, which we talked about. It's our mechanoreceptor, our touch receptor. When you initially have pain, what's something that you often do? Yeah, you rub it, right? You start rubbing around on it, and sometimes that makes it feel better. So what's going on there? Okay, so here's our A beta, and it's going up to the dorsal columns. But when it comes into the spinal cord, it also gives off a collateral. And again, there can be more than one interneuron, but ultimately it activates, we did that, okay. It activates an inhibitory interneuron that will now decrease the firing rate of that dorsal horn neuron. So there's a physiological basis why you start rubbing an area, or something aches, you know, a good massage, somebody really just kind of rubbing it and manipulating it in a certain way. And that's because you're activating those A betas, in part, which are synapsing on that inhibitory interneuron, which is then going to decrease the output of that dorsal horn neuron. So there's one intrinsic mechanism. And there's now this new technique called transcutaneous electrical stimulation, where they just put a little device like you have back pain. They'll put it on the muscle and it'll send out these pulses. And it's kind of in the range that activates those A beta fibers. That's how it's thought to work, and then help to decrease dorsal horn neuron output. I said before that the periaqueductal gray was also involved in modulating pain. So let's see how that works. Here's our DRG neuron from pain receptors, synapses on our dorsal horn neuron. Dorsal horn neuron gives rise to the spinal, gives rise to the spinal thalamic tract. And most of those axons are going to continue on up to the thalamus. But here's a little group that peel off in the midbrain and synapse on neurons in the periaqueductal gray. Those neurons can also be active. They have a lot of opiate receptors. And there are intrinsic opiates that we have in the body, like enkephalin and dynorphin. But let's just activate our PAG neuron. That neuron sends an axon back down through the brainstem, and it synapses on neurons that are located in the midline called the raphe of the pons. And that neuron contains serotonin. That serotonergic neuron goes back down to the spinal cord. And yeah, let's look at it here. Okay, so again, here's our dorsal horn neuron that's sending the pain signal up to the cortex. Here's our C fiber coming in and activating the dorsal horn neuron. Here's that axon coming down from the raphe. And it releases serotonin, which activates again, an interneuron, and that interneuron synapses on the terminal of the C fiber. It hyperpolarizes that axon terminal. If I hyperpolarize an axon terminal, is it going to release neurotransmitter? No calcium is going to come in. We're not going to elicit that whole response. So basically, in this system, we're still affecting the activity in the dorsal horn neuron, but we're doing it by inhibiting the C fiber from releasing neurotransmitter. There are also cells that are activated by the PAG that come out of an area called the locus coeruleus, which release norepinephrine. And that is on the dorsal horn cell, and it will inhibit it. So that PAG output's coming down into the reticular formation of the pons, and those chemically defined axons, serotonergic, noradrenergic, are going to come down and basically either block release of neurotransmitter or block the activity of the dorsal horn neuron itself. These are intrinsic mechanisms. You know, you hear about people who are in pain, soldiers fighting, and yet they can go on for a period of time or rescue somebody. And then when it's all over, it's like, oh my God, you know, I'm in agony. And part of it is thought to be mediated by some of these intrinsic mechanisms. Of course, there's also opioids, which we know have benefits, but which also have bad side effects. And the mechanism, let's put this up here. Okay. So here's a dopaminergic terminal. And these little cubes are dopamine, and they bind to receptors on a postsynaptic cell. Now, these terminals also have GABA receptors, and if GABA is released from this GABAergic neuron, it prevents, again, it will hyperpolarize that terminal and prevent release of dopamine. When you have opioids present, here's our morphine, binds to an opioid receptor, and one of the effects is that it prevents GABA from being released. If GABA is not released, there's no inhibition of the dopamine, and it is released. And by, mechanisms that are still not all that clear, especially if it gets released in areas of the brain like the nucleus accumbens, the ventral striatum area, it produces that feeling of euphoria, the pleasant feeling, and that is what causes, ultimately, the addiction. Because you feel so good, you don't want to keep seeking more and more, and we could do a whole lecture just on opioids and how they work. But that's more of an extrinsic mechanism for alleviating pain. We also talked about NSAIDs, we talked about the non-steroidal anti-inflammatories and acetaminophen in the last lecture. Okay, so I leave you with a pleasant picture. Touch also can activate through that secondary sensory cortex. We do know there are some very strong emotions that can be associated with touch. And we see some of those here. So I didn't want you to think that touch is only kind of this up, down, we just needed to manipulate things and that. And that again is mediated through that cingulate and insular secondary somatosensory cortex. I just think this is a nice picture to end it with. I wish you all a nice break.